Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover thyroid nodules and neoplasms. Okay, so let's begin with the thyroid nodules for this video because this is the matter that is more commonly tested. Okay, so let's describe that these ones usually occur in around 6% of the population, which is in fact a lot of people, right? And the majority of them, around 95%, are cold. So non-functioning nodules, these are the majority ones. Unfortunately, the cold ones are the ones related to malignancy, but they usually are goiter cysts, which are benign, or follicular adenomas, which are also benign. And these are more commonly seen in women. That's the reason behind that there's an increased risk for malignancy if the patient is either men or children. And also, if the patient has a history of neck radiation, this increases a lot the risk for malignancy. So let's go for the evaluation of thyroid nodules, okay, which is going to be pretty important. They like to ask about it. And so the first thing that you will do is to check for the risk factors. The patient is men, children, if they have a previous radiation history, if they have a familial syndrome, etc. Check these ones. Perform a physical examination in order for you to palpate the nodule to make sure to order your further tests. And so it is described that the next step in evaluation is usually the TSH. This is going to be your number one next step. And so in real life, what you do is you usually perform both of them, the ultrasound and the TSH, because they are both going to tell you different things that may lead you to the diagnosis, okay? So remember that these are in regards for you to discard hot nodules, okay? What you're doing here is you want to discard hot nodules because these are the ones that are non-malignant and that you can put some treatment in these patients. But okay, so let's focus first on the ultrasound. So the ultrasound is going to tell you many characteristics of the lesion, but if you suspect that it is a high risk for malignancy due to calcifications, irregular borders, increased vascularity, higher than 2 centimeters, then what you might perform is an FNA. You want to see what's in there, okay? Then your TSH, remember I told you that this is in regards for you to make the diagnosis of hot nodules. So everything that is not telling you that it is a hot nodule, the TSH being normal, the TSH being elevated, then you perform fine needle aspiration. Why? Because this is telling you that the TSH is not being altered by an increased thyroid hormone. Remember that when you have increased thyroid hormones, the TSH is going to go down. So if it is normal or increased, then you may have what is a cold nodule, and you want to avoid missing the diagnosis of a cancer, right? Now, if the TSH is low, this is telling you that there might be T4, T3 increased, right? So this is leading you to think that there might be a hot nodule. And so what you next perform is a radioactive iodine uptake. And if it is cold, then you follow with the FNA, right? But if it is hot, then you have your diagnosis. You have a decreased TSH with increased radioactive iodine uptake in the gland, telling you that this is a hot nodule, so you must treat for hyperthyroidism. So remember this in regards to diagnosing hot nodules. Everything else must be followed by a fine needle aspiration test. So just before jumping to the specifics of the neoplasms, let's differentiate between how the benign tumors of the thyroid and the malignant tumors of the thyroid behave. So the benign ones are usually described as being surrounded by a complete capsule. And this one usually has no invasion of this capsule and are pretty well defined lesions, okay? They usually have no cysts and no hemorrhage. And now the most common cause of benign tumor of the thyroid is going to be follicular adenoma. They usually present, as we've seen, as cold nodules, and the benign and malignant nodules are usually cold nodules. That's the reason behind performing fine needle aspiration to all of these cold nodule presentations. They can be follicular, papillary, Hortal cells, and 10% of them progress to malignancy. Now, for the malignant ones, they are usually described as having necrosis on the biopsy, presence of hemorrhage, invasion of the capsule, okay, and metastasis to lymph nodes, to distant organs, and to the surrounding tissues. It includes the ones that we're going to further describe, which are papillary, follicular, medullary carcinomas, and the anaplastic variant. And so this one's going to be the last part of the video. We're going to go to the specifics of these thyroid cancers, and we're going to review risk factors and mutations, how it looks on biopsy, the metastasis, how it spreads, where it spreads, and the treatment, since these are the things that you may be asked on the exam. So the first one's going to be papillary. This one's the most common endocrine and thyroid cancer. Okay, so it's the most common for endocrine and thyroid cancers. It usually presents in women more than men with a ratio of 3:1. It appears usually at the ages of 40 to 80 years. They usually have a history of radiation exposure, and this is the most important risk factor for this condition, and it is related to RET and BRAF mutations. Now, the biopsy. This is the one in which you're going to see, of course, the papillary fronts, as the name implies. The orphan NEIs, remember these ones are the ones with the nuclei, with the chromatin at the sides. And that's why they are calling them the orphan NEIs. And the calcifications described as psammoma bodis. The metastasis of this condition is usually through lymphatic invasion. This is important. They like to ask. It goes usually to the lung and to the cervical nodes. Okay, this one has a survival rate of 95%. It is usually treated with surgical removal. As it may appear as multifocal, they usually perform a complete thyroidectomy. So keep this in mind. For these conditions, they usually perform total thyroid resection. These patients are going to be hypothyroid after the treatment, okay? And you're going to have to replace thyroid hormones for them. Next one's going to be follicular. And this one, see how the rates drop from this one. This one is the most common in endocrine, and this one is only 10% of the thyroid cancers. Okay? And this one is also more seen in women than men, 40 to 80 years also. It is related to RAS, PAX8, and PPAR gamma mutations. On biopsy, this is described as a follicular, but to differentiate this one from follicular adenoma, this is important, capsular invasion. Remember we talked about it. And this one, vessel invasion. And it is because metastasis for this one is usually hematogenously. This is one of the few carcinomas that is spread like this. They like to ask this one. They go to the lung and to the bones. Now the treatment, the same surgical removal of the gland. It usually presents a solitary nodule, but don't mind that. It usually requires further radiation of the gland or further radioiodine uptake to ablate the gland. So they better perform surgical complete removal of the thyroid, okay? The survival rate is also pretty good, with more than 80% of the patients being healthy 5 years after the removal of the gland. Now the medullary one, this one is rare, 3 to 4%. And it is mostly sporadic. Notice it is 80% sporadic, but it is related to men's syndromes, right? 2A and 2B. Remember the 2A being medullary carcinoma, pheochromocytoma, and parathyroid hyperplasia, and then the 2B being the same first two pathologies, medullary carcinoma, pheochromocytoma, but these patients usually have mucosal neuromas or Marfanoid habitus. So keep this in mind. These are usually red mutations, the MEN2A and MEN2B. Now, this in biopsy, what you're going to see are the parafollicular C cells. These are the ones that produce calcitonin. And so this is usually a good marker for the disease. These patients usually have elevated calcitonin. And remember, this is the hormone that drops the serum calcium levels, okay? Now, they usually present with amyloid, and it is usually due to the calcitonin. They stain positively for Congo Ref due to the amyloid, okay? Now the metastasis, it is usually lymphatic invasion. It can also spread by direct invasion, but it usually does by lymphatic invasion. It goes to the nodes, it goes to the liver, and this one's important because as these follicular cells can also generate other types of hormones, they can develop into other syndromes such as carcinoid syndrome producing serotonin. It can also develop into Cushing syndrome with the development of ACTH. So keep this in mind for this pathology. It goes to the lung. It can also go to the bones. Now the treatment, this one also is surgical removal, but the important thing is that you need to check calcitonin levels at around 6 months after removal. This allows for the calcitonin levels to normalize, and then if you see that they are also elevated, then you are thinking of a possible metastasis. And now the last one, the anaplastic one, this one's pretty rare, 1% only. It usually presents in elderly women that had a previous multinodular goiter or thyroid cancer, okay? So they have that as a history. The biopsy, as the name says, undifferentiated cells, undifferentiated tissue. Metastasis, this one goes by direct extension. It actually grows super fast. It generates an enlarged thyroid gland massively. And the thing with this one is that even with resection, the survival rate is pretty low, with 5% at 5 years. And then the last one is going to be the one we mentioned with the thyroiditis, the primary B-cell malignant lymphoma of the thyroid. Remember, it is associated with Hashimoto thyroiditis if the disease goes for long enough and it is not well controlled, but they usually have good prognosis. You usually perform treatment for the lymphoma or resection, okay? And that's going to be for thyroid cancer.